Thank you, Professor Ross, for this very inspiring speech and also said very good for this whole conference, health and complexity. So now we will move to a very complex issue, public health issue, is the global obesity epidemic. So my name is Ampan, and it's really my great pleasure to be the moderator for this session. And I come a long way from the Huazhong University of Science and Technology in Wuhan, China. And we all know that obesity is a major public health problem around the world. And it's also a major risk factor for many chronic diseases. And we also have abundant evidence, actually, for prevention and control obesity at the individual level, at the national level, regional level, and global level. We do have a lot of policies. However, we are still seeing an increasing trend of obesity across the populations, and also its related chronic diseases, with very, very few exceptions. So I think we do need complex thinking. We do need innovative thinking and also innovative strategies to tackle this problem. So today we are very privileged to have Professor Charles Agyemang from the University Medical Center of Amsterdam to give us his new thinking of obesity prevention strategies. And Charles is very, very well known for his remarkable work in global migration, ethnicity, and health. He's also an adjunct professor at the Department of Medicine, Johns Hopkins University, and also the vice president of the Migration and Health section of the European Public Health Association. So without further ado, let's welcome Professor Charles Agyemang. Charles, the stage is yours.
Thank you so much for this great opportunity to come here today to talk to you about some of the work that we are doing. When I was asked to come and talk about global obesity and cardiometabolic disease, I said to myself, I need a couple of days. And to give this within a short period wouldn't be justice. So what I'm going to do is basically to tell you about it, but look at it from different angles. So I'm going to talk a little bit about it, and also to show you some of the lessons from the RODAM study. And I think this is an excellent opportunity because the RODAM study is based on African population, and there's no better place to deliver this within the African soil. So I'm very, very grateful. And also I'm very grateful to the organizers for giving me this opportunity to talk to you today. Well, I think before I will start, I think it's very, very important to highlight that the global health systems have made a tremendous amount of gains in the last few decades. Today, if you look at maternal mortality, if you look at under 5 mortality, all of them are coming down. So you have made a huge progress. But of all this progress, there's also a huge inequalities that we see across the global level. There are also many, many challenges that actually remain. Still, communicable diseases is a huge burden in all parts of the world. And we are also experiencing the epidemic of non-communicable diseases. And you know that actually the low and middle income countries are basically enduring the large chunk of it. Nearly 77% of all the NC deaths actually happening in low and middle income countries. And of course, cardiometabolic disease actually accounts for the large part of all the non-communicable diseases. In fact, diabetes and cardiovascular disease are almost responsible for nearly half of the NCDs that we are talking about. So effectively, cardiometabolic diseases is a huge problem. And of course, this is also reflect on global epidemic of obesity. Today, in 2022, almost 2.5 billion adults are now living with either overweight or obesity. And this is almost about 43% of all the adult population. And we also know that actually this varies across world regions, spanning from nearly 31 in Africa and Southeast Asia to nearly 67% in the Americas. But many of these low and middle income countries are catching up very, very fast. Unfortunately, if you look at the projections it also doesn't look good unless active action is taken in place. All the implication is that this epidemic is going to continue. We are also living in a situation whereby, in terms of the cardiometabolic disease, it's changing. Now the morbidity is actually getting a huge problem. People often live with not only one, but multiple of these conditions. And our chronic disease care models is also get stuck. Now you only focus on one specific diseases. We need integrated care. And of course, as a result of that, we miss these opportunities for diagnosis and management of many of these conditions. So actually, you can put it in a very short part to see what is actually happening, right? Social determinants of health and other drivers such as globalization, migration, and urbanization, which is influencing, behavioral risk factors, and this is actually driving the metabolic risk and subsequently leading to cardiometabolic diseases. So that is basically how you can actually put it very simply. But you also know that actually when you look at these conditions, some specific populations, such as the migrant population and the urban populations, have been most affected. And of course, if you look at this population, there are many ways you actually can study this population. And here I've described it extensively elsewhere. First, you can compare the migrant population with the host population. This is what you call the ethnic inequalities. Or you decided to look at the context, whereby you compare similar population, but they live in a different context. And third is what you call the role of migration, where you compare the migrant to the population in their home countries. And of course, if you look at the role of ethnic inequalities, we see that in all the cardiometabolic diseases, these populations tend to be highly affected. Let's take about diabetes, for example. We know that the migrant population tend to have a higher rate of both morbidity as well as mortality when relating to diabetes. And they also tend to develop these conditions much earlier compared to the host population. And some of the risk factors that we've already mentioned about, such as obesity, insulin resistance, and others, these things also tend to be higher. And I've shown you this graph that we studied that we did a couple of years ago, where we looked at, within Europe, when you are looking at diabetes, right? You pull all the data from different population. In all the population, it clearly indicates that if you are a migrant and living in Europe, you tend to have much higher rate of diabetes, particularly among the South Asian population. And if you zoom in, actually, you see that if you look at particularly the Bangladeshi population, the odds of diabetes was more than 6 times compared to the European population. And of course, what is also very interesting is that when you are comparing the migrant with their host, or to their migrant population, to those that did not migrate and living in their home countries, there you can learn a lot from. Why do you want to do that? And I think that this is one of the actually most excellent forms where you can actually start to really beginning to understand what is actually happening. One, it can actually reveal the real-life changes upon migration, and therefore pinpointing the key predisposing factors. And also, I think that this is also provide an indication of actually what is going to happen among those that are not living. Many of these lower middle-income countries are actually changing, right? So what we see among migrants who have migrated actually will give an indication of what is going to happen in the future. And I think another important part is an effective model for collaboration between countries, particularly for the host and this. And of course, when you talk about migration part, you've already learned a lot. Several decades ago, a very famous study by Malmot and the group where they actually show that if you compare the Japanese men living in Japan to those that have actually migrated and living in Hawaii and California, those that have migrated tend to have a higher rate. Similar work was done in India, where, looking at Punjabi people living in West London tend to have a higher rate also on the coronary risk compared to their siblings living in India. So we decided actually it is an excellent opportunity. So we set up a very unique study, my team, called the RODAM study. And this work has now become a very, very well-known study globally now. So you have a very nice website. So those of you that want this afternoon, please join us as well. We'll be able to explain much of this to you. But for the main work of the RODAM study, the idea was basically to try to look at gene-environmental interactions and how they influence cardiometabolic diseases among the African population. And in doing so, we came out with a very unique cohort. And we start with actually the Ghanaian population that living in rural Ghana, those that are living in urban Ghana, and Ghanaian population that is moved to London, moved to Amsterdam, and those living in Berlin. And with this group, you wanted to sample about 1,250 from this population. But if you look at the pie chart, you see that the Berlin, the numbers were slightly a little bit lower. So Amsterdam and Ghana oversamples to make up of what is done. And to look at this type of work, you need a very strong team in order to be able to do this type of work. And luckily, we did have all the teams were highly committed to be able to do it. And then also, of course, you see that, group of deaths, and some of them are celebrating. I'm talking about cardiometabolic. You see cake over there, but don't mind. They decided to enjoy it because they've got the numbers. But to do this as well, I think it's equally very, very important that, the standardization is key when you're doing this type of work. So the work was clearly standardized. Even the sample were all shipped to one part, so that we ensure that, you avoid intra-laboratory variability. So what I'm going to tell you is basically some of the lessons that you've learned from this unique cohort. First is that migration influences cardiometabolic diseases and then also the management among this population. And if you look at this, particularly I want to emphasize that this population that we are looking at is exactly the same population. The only thing is that some are living in the rural, some are living in urban, and some have migrated. So if you look in men on your left, you see that when you look at those living in the rural Ghana, overweight and obesity rate is just about 9%. And this moved to nearly 39% in those living in urban, and can even rise up to nearly 74% among those that have moved to London. And even within those that live in different European countries, you see that the Berlin is doing well. So clearly, context clearly seems to influence cardiometabolic conditions that we are currently seeing. And in women, the rate was actually shocking, from nearly 34 in the rural up to 69 or 70 in urban to nearly 90 in London. And of course, you see similarly, when you look at diabetes, again, you see a similar patterns. And again, here, what is very interesting is that you also see that actually within the urban centers, diabetes rate is actually catching up with the migrant communities. And this is not only in Ghana, this is also across many parts of the world. The same thing when you also look at hypertension or high blood pressure. Another lesson we learned was that nutrition or diet also seems to play a very, very important role in relation to cardiometabolic diseases. And I will tend to show this graph because actually it really depicts what is actually happening on the global scale. Let's take basically soda and juice because of time. And what we are seeing that when you look at those living in the rural part, which is the green bar, they consume just about 70 grams per day. And this moved to almost 100 and to nearly 400 among those that have migrated. So nutrition changes tremendously based on what you have actually do. And when you publish this work, actually, New York Times picked it up. They spoke to me. And they came out with this beautiful title, what they wrote about the work. And said obesity was rising as Ghana embraced fast food, then came KFC. And this is exactly basically what we are seeing across the global scale. In urban centers and others, the big food is taking over. And of course, the traditional food and others is actually now being looked down upon. Another lesson that we learned from this is also related to epigenetics. We clearly find that actually migration seems to influence epigenome when people move, actually. And of course, you've published mountains of this on epigenetic. Because of time, I won't have time to go through it. But I will just pick just one example. You look at diabetes. And what you saw that we identified for kilosize, and within this, sex-differentiated methylated position explain nearly 25% of the variability in terms of type 2 diabetes. So epigenetic seems to play a very, very important role. Another lesson that came out from this study is also migration seems to influence micro and macrovascular complications. You know, I've just been talking to you about the non-migrants tend to do a little bit well, but when it comes to complications, it appears that actually those living in the rural communities and living in the urban communities actually having a big problems. And the problem has to do with the fact that those living in our rural communities and urban centers, access to healthcare in treatment is a major burden. And that means that many, many people, although they do have as the migrants, but once they develop the condition, the treatment and others become an issue. And this work we published clearly looking at nephropathy, peripheral arterial disease, coronary artery disease, and stroke. You see that actually the migrants seems to be doing well, because they do tend to have access to a better treatment. Another lesson we learned, yesterday we heard this beautiful talk about the need for capacity building. And this work, the capacity building has been actually huge, and also opportunity for intervention. And when we initially thought that, starting this work, actually I didn't imagine that you could be able to sort of build this capacity around it. Overall, about 10 PhDs have completed their work on this work, and then about 5 are currently ongoing. And basically, so many master students have benefited from it. So the capacity building has been huge in this type of work. Another important part is also in terms of that, is based on this, we've actually built memorandum of understanding with the University of Ghana. So now we are doing a lot across clinical level where we are doing exchange. And also now you set up a summer school every year. You have population from Amsterdam, PhD students, and PhD students across Ghana. So this has led to this excellent opportunity to be able to actually build capacity around this. Another important part when you do this work is actually what came out of this. And this program is called Your Health is Your Wealth program in Amsterdam. And actually, this work, one day I was sitting in my office, and one of these gentlemen came to me and just said, Professor Agyemang, you've been doing a lot of work, coming into our community, you talk to us, everything. What can we do together in order to basically to make a difference in our community? So, if you are epidemiology, public health, you sit on your table and then going, yes, that's it. So since then, we've basically been working with these communities. We provide them every year. You give the glucometers, you give blood pressure monitors, and the community come together. You make tents, and then all the community come together, and the medical students loves it. So you come in, you make a nice things out of it. The community comes together. You measure their blood pressure and others, and it's become hugely successful. Initially, you thought you were doing it for migrants, but now it's become for the whole community, which is a wonderful thing. Another part also has to do with, initially when I was writing, we thought that this is only for the migrants. But it turns out that it also has a huge benefit from where the migrant population comes from. And here we did a very nice program back in Ghana with the Ministry of Health and, to basically to give this study back to it. And and these young people over here, many of them have had their masters, and many have had their PhD out of the program. And also, based on this work, it's also kind of, if you like, a spin-off work. After this work, a colleague reached out to me, who is now the director of IDLC Canada, and just said that how can you use this knowledge to basically make improvement? So based on this, we are now doing a very nice work, basically looking at the nature and the extent of unhealthy food and non-alcoholic beverages promotion on television and in stores around schools areas. Big Food are targeting schools, targeting young people. So you are trying to figure it out how you can actually protect this young population from developing these cardiometabolic diseases. And with the success of this program, now it's been scaled up to, in Kenya and Tanzania. So that is an excellent opportunity as well. And we also, based on the same program, we've now started what we call Generation H project, which I'm very happy to lead. And now you're basically looking at how can we protect the young people from developing this cardiovascular disease in the first place. So now you are looking at unhealthy diet and physical activity and the underlying social determinants among Ghanaians, adolescents, and Kenyan adolescents. And we do this by basically designing, deploying and evaluating the strategies of the implementation of evidence-based. And we are hoping to map this into WHO best buys. And this has just been taken off very, very nicely. And also with the success of this, for the RODAM study, now for the first time, actually, you've managed to get the opportunity to transform it into a prospective cohort. So this will be the first prospective cohort of its kind, where you are following the migrating population and non-migrating population, and with time, you'll be able to get a wonderful data to be able to make a difference to the community. But of course, what I've just told you about is just part of, there is still a lot of challenges up there. WHO has come out with the best buys and the other recommended interventions, but it's still a long, long way to go. And there was a report from the Global Report on Hypertension, which was very well depressing. With all what is happening, if you look at in terms of, hypertension diagnosis, treatment, and others, the rates are very, very low. Management today in many Africa and Southeast Asia is less than 15%. Why? So it's a lot needs to happen. The same thing with when you look at statin. This is the data that you have. Those people already suffering from cardiovascular disease, look at the prescription rate. In many parts of the world, it's less than 10%. The same thing when you look at the obesity preparedness. This was the work that's actually by the World Obesity Federation. And here we see that the higher, basically the lower the score, the better the preparedness. And you see that in Africa, East Mediterranean, these numbers are pretty depressing, right? And this has to do with lack of political will, lack of training, healthcare costs, and so many different factors. And that also means that the target that we are all hoping to achieve, actually, for me, if you look at what is going on, there is this, you are not going to achieve many of these. Some of you are optimistic, but I'm not, actually. And this has to do with work that we published a while ago. We wanted to look at tracing African progress towards implementing the non-communicable disease global action plan, 2013 to 2020. And you see where I have highlighted. That says it's all. Our findings suggest that Africa is off track in achieving the non-communicable disease action plan. What you saw, that was not even a progress, it was a retraction. And this is happening in many, many parts of the world. So what needs to happen? I think that we need national and international commitment to tackle the problem head on. And we also need to ensure that these commitments are actually translated into action, and you also need to track the indicators. We've done enough talking, actually, so you need to really start to walk in the talk. Right? You've talked a lot, so let's start actually walking the talk, all right? And in doing so, you need to adapt and evaluate the strategies for implementation by mapping on into WHO best buy. And I think that I want to emphasize that you should avoid copy and paste, syndrome that you do have. You just see that and then you just copy it here. There are so many differences in context, and we need to take those contexts into account. It's very, very important. And also, we need effective integrated care models for cardiometabolic multimorbidity. Now, today, you see many people with hypertension. They go to hypertension clinic, diabetes clinic, cholesterol, and others. Why? We need to come up with integrated care where the patient can go to one place and receive all the care that they need. So to conclude, well, we say that today, obesity and cardiometabolic disease is a major, major burden, right? And we also know that prevention strategies and management of the problem certainly remains a suboptimal, particularly among low and middle income countries. We need international and national commitment to address the problem. And in doing so, we really need to basically start to adapt, evaluate, and implement, and also to scale it up to many countries, taking the context into account. Thank you very much for the opportunity to talk to you today. Thank you. Thank you. Thank you.